morning. So,
Good afternoon, everybody. Good evening, I should say, and thank you all for attending this evening and giving us your time. I do apologize profusely for coming on late. We do have a technical issue with um, Dr. Kulkarni's audio, so he is just fixing that as we speak. So I will kick off. I've got a couple of slides to go through with you and hopefully Nick is ready when I have finished that. So this evening you will be watching a webinar which will be just over an hour, probably about an hour 15, an hour 20. It's presented to you by Dr. Nick Kulkarni, and we have a special guest at the end, Dr. Minu Villani, who will be touching a little bit on dental sedation in the dental practice, and a very comprehensive course that him and Dr. Kulkarni are running together in July. So I thank both of them for their time this evening. My name is Ashi Shaddock. I work for W9 Arc Health. And I will help present all of the stuff this evening. A few housekeeping things for this evening. I strongly encourage you to place any question. There's no silly question. Place any question in the chat box at the bottom of Zoom. We will do a live Q&A at the end of this session. So any questions you have, please type them in the chat box and we will go through that at the end. Your CPD certificates will be with you no later than Friday. If you don't get them, please make sure you check your junk email and your spam email. Make sure that if you don't receive it by sort of Monday afternoon, please get in touch. The recording will also follow. So Friday, around the same time, you should be getting both. So keep an eye out on them. And I do kindly ask you that if you could stay on post this webinar and complete a very, very quick, and I promise you it's very quick, a very quick survey just to get your feedback to help us keep delivering what you guys want from us in our webinars. Tonight we are offering an exclusive webinar offer for EthOss, and it is buy any 2 boxes of EthOss and you'll save 15%, and you will also receive a free sterile implant draping kit. Now to do this, you can contact Arc Health to order, or you can contact myself. That's my number also. I would also strongly suggest for anybody that isn't already a member of the EthOss Case Studies group on Facebook, please go and join this group. It is a closed group. It is peer-to-peer. You will see the good, the bad, and the ugly, but mostly the good. It is very educational. It is run by the UK with Dr. Fairburn on it every sort of 8 to 12 hours. If you are waiting on an answer or a question on that, just please keep in mind that the time difference, because that is run predominantly by the UK. But they are very, very active on there. So if Nick is ready for you guys, I will hand over to him. Nick, can you hear me? And can I hear you? No, I can't hear you. So just unmute your microphone. No. Sorry, everybody. Just bear with us for a second while we fix this audio issue. I do apologize.
Yeah.
Okay, so I'm sorry about that, everybody. I'm just going to see whether or not you can hear Nick through my phone, and we will go from there. So, Minu, I'm going to need your help for this. Can let me know if you can hear Nick.
Say something, Nick.
Can you hear me?
Yes, I can.
Can you hear me, Minu?
Yes, I can.
Okay. So should we proceed like this?
Well, unless you can get your microphone up and running, I think we have no choice.
Yeah, my microphone is not really working for some reason.
Is it echoing, Minu?
It is.
It is. Okay.
It's not ideal.
Nick, can you hang on 1 second? Hang on.
Yeah. Can you hear me?
Yes,
Is it echoing?
it's echoing.
Okay, Nick, go. Can you talk?
I can talk, yeah.
Okay, that's working perfectly. So you'll share your screen from your computer, but you'll use your audio from your phone.
Okay.
Okay,
If
all
that,
right.
if
I'm
that
so
works,
sorry,
yeah.
everybody. Thank you for hanging on there. I know that technical difficulties can be very frustrating. So I'm going to stop sharing my screen, and Nick, I'll let you take over. Thank you so much for this evening. I know everybody is in for a treat with all of your cases. They're phenomenal. If we could keep it, we're running over time by 15 minutes now. So if we could keep you to an hour, that would be much appreciated. And then that will give Manu the time that he needs also. So without further ado, I'll hand over to you and thank you very much. Just share your screen now with your presentation.
Yeah. Okay. It's asking me to replace current screen.
Yep. So you can put your phone down. We don't need to see you through that. We need to see you through your other. And okay, your screen is sharing. Okay, we can now see your screen. So just do your presentation now as normal.
Okay.
Okay, thank you so much, Nick. Just keep your phone near you.
Yeah, I've got it.
Okay,
Yeah.
excellent. Fantastic. That looks good and sounds good. Off you
That's
go.
working all right. Okay.
Yep.
My
Thank you.
apologies to everyone. We've had a comms issue and I have no idea why. But anyway, let's get into the dental implant side of things. So it probably ease off the burden a little bit. And I appreciate and thank everyone for their patience. Simplifying dental implants in private practice, right? We are all in private practice and you don't really want to make your life hard. So this is what I do in my practice, and I'd just like to share some insights with you. Okay. So that's me. My name is Nick Kulkarni, and I've been in private practice since 2001. I graduated from University of Mumbai back then. Then I did my master's in prosthodontics, again, a very long time ago, from Russia. Then moved to Australia. I was in WA for a while, and then moved to Sydney, did my grad dip from Sydney Uni. I worked in between all of this. I was working in Dubai for a few years as a specialist prosthodontist and as a general dentist as well. So I've done ADC Dubai graduating exams, and yeah, so here I am with you all, and I love being in Sydney. I've got a small practice in Leichhardt, and I do a bit of referral work in and around New South Wales. Let's go on. I used a beta tricalcium phosphate product first time in 2006. I got good results back then, but I wasn't sure, there wasn't much evidence behind it, so I sort of stopped using and went back to xenografts or allografts. But beta tricalcium phosphate for bone grafting is not new. It's the first paper published for beta TCP was in the year 1900. So orthopedics have been using it. In dentistry, we've only just got onto it. Okay, so what is EthOss essentially, right? So it's a mixture of beta tricalcium phosphate with calcium sulfate. Primarily, the calcium sulfate helps in setting the beta tricalcium phosphate, and that creates a nice solid mix, which in turn turns into true host bone regeneration. So let's move on through other slides. There is no need for a collagen membrane. So at 12 weeks, this is a very interesting paper by Peter Faber. At 12 weeks after socket grafting, they did a trephine biopsy, and they found that there was about 50% turnover of new bone at 12 weeks, and very little old remnant biomaterial was left. And we see this in the practice all the time. Calcium sulfate is the key ingredient along with beta tricalcium phosphate, and the proportion of it together is the best thing we could really find. So once you mix it like plaster and you apply it in your site, it sets like dental stone or dental plaster. All right. Once it's set, that actually forms a hard coating, so no additional barrier membranes are required. The whole reason in grafting we use a barrier membrane is to prevent the epithelium from growing into the graft, because bone grows at a slower rate than epithelium. So once you've placed your graft, if you don't have a barrier membrane, when I talk about a graft, I'm talking about an allograft here, or a xenograft. Once you've placed your graft, if you don't prevent the soft tissue from ingressing into that graft, you will have no bone turnover. You want the bone cells or the osteoclasts and osteoblasts to come in and attack the bone graft to convert it to host bone. That's the reason why we use a membrane. With EthOss, if you use a membrane, you're actually working against the product, right? Also, EthOss sets and provides a nice volume to the whole defect. Now, we know that soft tissue loves to heal with a good support on it. So EthOss, once it's set, it provides that nice little base for the soft tissue to start growing on top of it. So we see this time and again, and I'll show you in my slides, where we get really, really nice soft tissue volume and soft tissue quality. Right? Why is EthOss my go-to material now? I basically don't keep anything else in my practice. It's synthetic, right? So it's much better to have conversation with patients when it comes to, whether it's porcine, whether it's bovine, so there's no religious problem with it. The risk of cross-contamination, 0. Good turnover rate at 50% at 8 weeks. So what we really want out of a bone graft is for its ability to form as close as possible to natural bone, right? So that's where we come to a true host regeneration. No need for membranes, so it's a much faster procedure. Better soft tissue profile once the graft is set. Ease of use. Now, I know it is a bit of a learning curve because we are reinventing the way we've been doing bone grafting for years. We are used to using xenografts where you want to saturate that bone graft with blood materials as we go. EthOss is very different. You want it to be as dry a field as possible. So it's easy to use, but it needs a slight change in the way we think about things. All right. And there's good local support from Arc Health, and it's also cost effective. So the cost of EthOss is probably less than cost of buying membranes and graft materials. So that's the reasons why I use EthOss in my practice. Let's get into the actual cases. The reason why the whole reason why we are here is to see cases and to be able to do them. Right? This patient presented with a 2-2 that had a history of trauma, history of root canal, and she was getting pain in that tooth with a significant infection in the periapical region. We can see that on the CBCT. Now, at that stage, I had 2 options. One, either to extract and do the implant, or the second option was to redo the endo, do an apical surgery, and then hope that everything works. So I presented both the options to her, and she said, "Look, it's." She would have preferred to have an implant so that it's done and dusted. Well, in my personal opinion, I would have favored an implant as well, because I've got another case where you do everything right, and then there's a little root fracture, and the whole thing is turned to dust. So, and you're back to the implant again. So the patient spent $2,000-3,000 on it, and then they're again spending more money to get the implant in. So we decided to extract it and do the implant. That was the incision. So extraction was reasonably simple. Now, but we know that there was a large defect at the base of the root. Raising a flap, we are seeing there's almost no buccal plate. It's pretty much resorbed. And then that's the eye of the storm. That's where that lesion actually sits. So this whole lesion was curated. I use Arc Health's or EthOss degranulation burrs to clean out this. These are diamond burrs, and they are really good at effectively cleaning the host bone. So, and then here on the left-hand side, you'll see there was a little bit of wet EthOss before placing the implant. So you do your curettage of the lesion, you do your osteotomy, then I would place a little bit of wet EthOss just to line that irregular defect, then push the implant through it, and this implant got a perfect anchorage of 35 newtons because we were going and engaging the apical area where there was still good host bone. So in all my cases, I try to get to the host bone, so at least the last few threads of the implant are anchored in really well. And then that's the grafting of the defect. And then that was suturing after, right? So here I've done a primary closure because in such cases, I know that I might have to go and regraft a second time. So we're going to raise the flap at stage 2 anyway. So we decided to get a nice, good primary closure. And this is at re-entry. So at re-entry, I'm raising a flap. I'm like, oh, where's that implant gone? So you have to actually dig into the bone to reach that implant. And you can see on the other slide where the implant is now found after taking away a bit of bone and making a bit of room for some amount of good profile for the crown. Oops. Yeah. All right. Can you still see the presentation and hear me?
Yes.
Yeah, okay. Something went on my thing. Anyway. And that's the final crown. That's a close-up. This image is taken at the time of crown insertion. So the soft tissue is not going to look the best at this stage. But I think she's quite happy. High smile lines. These are difficult cases to do. And that is a 2-year follow-up. So we're looking at good soft tissue contours we can see over here. And generally the smile is nice and aesthetic. And that's the money shot. So we go from before where we had a large lesion to and after we see good amount of buccal bone volume and it's still present. So I would say that was, the patient and I are very happy with this result. And that's the final before and after. So when I have these patients with such high smile lines, I sit down and have a very, very large and a long sort of an informed consent with them to make sure we are on the same page, because there is no turning back once you get a bad result in that kind of a smile line. So I always talk about the possibility of a longer tooth, possibility of the implant not being very aesthetic. So all this is factored into the informed consent before we start this. All right, lower anterior with significant grafting. Okay, so this case presented with a extraction was done by the referring dentist, but there was still a lot of granulation tissue inside. Now, when I'm looking at this case, I'm looking at reasonable soft tissue cover. There's not enough space to do 2 implants, so I would place 1 implant and have 2 teeth on it, because you want that implant area to have good access to hygiene. So from a prosthetic point of view, I think a 1 implant solution is probably better here than having 2 implants. That's the pre-op CBCT. Okay. That's full thickness flap raised. Then we degranulated the site really well with the degranulation burrs, and that's the host bone that was left. That's all the stuff that came out of the graft. Implant placed in host bone, always 35 newtons insertion torque. So that's good. Confident enough to place a healing abutment on the day itself. Then we go into some of the reasons and some of the tenets how you want the EthOss to be done. You want a dry and clean site. I mean, dry as possible. All right. I normally tend to release the periosteum before going ahead and doing the grafting, because once you've placed the EthOss, you don't really want too much bleeding in that site. Once you've done with the EthOss placement, you really want to just place the EthOss and close and suture up, and that's it. Then you're done. So I do all my soft tissue manipulation as much as possible before. All right, that's the healing abutment in place, sutures taken, and that's the graft. Now, when we pack EthOss in a site like this, you don't really want to overpack it or condense it really, really hard. You want to leave some room over there for the cells to regenerate through there. Okay. And this is at the time of impression, open tray impression. We are very pleased with the soft tissue profile. I think we've got a good result over there. And that is the final result. This case was done, I think, 3 or 4 years ago, possibly more. This is a 3-year follow-up, but this was a referral case. So the referring dentist sees the patient, and she said it looks exactly the same. So we had a good, successful result in the end. Another case. This was a case in my practice. A lower anterior with poor oral hygiene. So we talked about getting his hygiene up and XYZ, stabilizing the perio. He actually didn't have generalized perio. It was only just localized perio in this region. So, but once we got him on general perio maintenance, he was a good candidate at that stage to do an implant. Right. Again, large lesion. Right. On the left-hand side, we see the extraction's been done and the flap has just been raised. And then you see all this granulation tissue with just forming a big mass around that socket. And then we go with EthOss degranulation burrs, clean everything until you can actually scrape the bone. You can get fresh bleeding from the bone, because that's what you want. You want the bone cells, you want bleeding from the bone and not from the soft tissue for anything to work, for implants to work, for grafts to work. You want osteogenic bleeding rather than a soft tissue or periodontal bleeding to help with healing. Now we're placing the implant. Again, we got a good torque on this. The defect was grafted with EthOss. And then we did a primary closure on this area purely because I wasn't yet sure of this person's perio. So I said, well, rather than leaving it open, let's let it heal, cover it up really well, so that you can keep working on the oral hygiene maintenance. So we waited for 3 months of healing. Now, the good thing, if you see here, once we did a primary closure on it, and the fact that the EthOss was supporting that soft tissue, we can see there's a nice amount of keratinized tissue around it, which is the make or break of a lot of these cases. Right? And coming back to the slide before, we saw there was almost no buccal bone at all on the side of the implant. And now we have bone almost reaching up to the top 2 threads. Maybe a couple of threads are still out of bone. And I could have done another grafting procedure at this stage, but I decided to move along because there was good soft tissue. And I think that little bit of couple of threads of exposure of bone, I could live with that. That's the final crown. That's the sutures at stage 2. Healing abutment is placed. And this is the final result on the day of the crown delivery, right? And this is a 2-year post-op. I think it's been bit more than 2 years now. And this patient regularly comes in and he's in good maintenance. We can see his hygiene is really, really improved. There's no bleeding anywhere. There's no periostatus at the moment, and we can see that there's good amount of buccal bone. The implant is well centered in where in the bony envelope, and generally a happy result in the end. That's just a follow-up of everything tied up together. That's at 2.5 years. Now, timing of implant placement. Now, we have immediate implant placement, early implant placement at 8 weeks, early placement with partial bone healing at 12 to 16 weeks, and late placement more than 6 months after extraction. Now, the type 1A, which is the immediate implant placement, that is a great way to do it, and the results are quite good, but it's very technique sensitive. So if you want to make your dental implant practice a bit more predictable, I think a good way is to wait for the soft tissue to heal. So then if you're grafting or anything, you got a good soft tissue cover that increases the chance of success much better. All right. Delayed versus immediate. Conclusions. Okay. Similar survival rates between type 1 and type 2. Now, each of us as clinicians, we have to find our niche, and what works best in our hands is what works for us. Right. I tend to be a bit more cautious when in doubt, but I do both type 1A and type 2 as well. So generally, the prescription by EthOss is extract, wait for the soft tissue to heal, wait for 8 weeks, then go in, place your implant, place your graft, and that's the protocol that is most recommended by Peter Faber as well. Okay, does immediate implant placement prevent residual ridge resorption? And if you want the long answer, you can read this beautiful paper by Arajo. But the short answer is no. Immediate implants won't really prevent residual ridge resorption because that's biology. As soon as you extract the tooth, you are going to lose that 2 to 3 millimeters of that bundle bone on the buccal plate that you have, because the blood supply to that bundle bone is from the PDL of the root and not from the periosteum. So once the tooth is gone, we are going to have some amount of recession, and that's why in most cases in the anterior region, or in a lot of even in the premolars or even posterior regions, we need some amount of grafting. So grafting is a part of our life now. So this is a case where I've added this case to show or demonstrate socket graft. Now, I normally don't really do socket grafts. My standard protocol is extract, do an immediate if I can, if everything allows me to do immediate, or else wait for 8 weeks for soft tissue healing, let the socket heal with just a blood clot, and then go back in and do the implant and grafting. I would do a socket graft if the patient is undecisive or undecided about which way they want to go. Because this was a lower first premolar, and she said, "Oh, I don't really smile that wide. I may not, I may not do the implant." I said, "That's fine. Let's take the tooth out. Let's graft. And then if you still feel you want an implant, then we can always do it." So in this case, I did a socket graft. Extraction done on the left-hand side. On the right-hand side, we can see there is EthOss grafted in place. Again, not really packed in, but loosely placed in. And here I did a primary closure. Again, you can sort of, there's one of the questions that always comes up is, can we leave EthOss open? And the answer is yes, you can, but I just prefer, if I can, at least bring the edges of the wound as close as possible, if not complete primary closure, but as close as possible. I don't like to leave things exposed as much as I can. Right, and then we reap the rewards for it, because we see that there's good amount of keratinized tissue, which is very important for long-term success. All right, then we go in. We've maintained the buccal volume here. This is at 12 weeks. We enter the site, and that's the osteotomy, right? Let's move on. That's the implant in place. Then I've got a little video for the actual insertion of the implant. We got a good torque on this, right? And we've got other videos here. Now that's the implant. Healing abutment is already in place. The flap has been relieved. Now we are ready for grafting. So that's the little release video for the flap. That's the EthOss going in. All right. So you mix the EthOss, you keep your soft tissue ready for it to go. You mix your EthOss, plug it in there, pat it there in that region. Just contouring it with the idea that this is how you want the bone to heal. We are going to see some amount of resorption there, but you generally want that contour to help with bone healing and soft tissue. And then you place a little gauze on top of it and wait for 2-3 minutes for it to nicely dry up. And once it's dried, you should be able to sort of pat on it, tap on it. See, your elevator bounces off. That's how you want the EthOss to be set. This is really good now. All right. And then we are doing some soft tissue closure. We want, well, I think this video is before I did the grafting. So I think this is just to show the flap reflection and flap mobility before we start the grafting. Okay, so photos again, EthOss in place, and then we've got the site sutured with the healing abutment in place. Coming back to restoring it, we are having the open tray impression. That's the soft tissue cuff that we can see, and then a customized healing abutment just to increase the soft tissue, just to shape the soft tissue so that when we place the crown, we don't have too much blanching at that time because it's only a narrow implant, it's a tight side. So it's just some amount of flowable composite around a healing abutment to customize the healing abutment essentially. And that's the final result, right? So we've got a pleasant looking restoration with good soft tissue coverage. The shade is a little bit whiter, but she wants to do bleaching, and I think we did some whitening, and in the smile line, it sort of blends in. So I think she's generally quite happy with the result. All right, key steps in implant planning. Prognosis of the tooth. This we do this all the time. I've just placed a slide over here just for just to summarize everything, right? Prognosis of the tooth, planning of extraction, strategic value of the tooth. I don't really, unless the patient wants and unless the occlusion really favors it, I don't talk about an implant in the 7 regions because I think if it's an older patient who's lost a 7, sometimes you can live without having the 3-7 or the 2-7 right? Are we doing grafting or not? What kind of protocol are we doing? Are we doing immediate placement, delayed placement? These are all the kind of questions we start thinking about once we are doing pretty much any treatment, really. What's the occlusion like? What are the anatomical considerations? So in a side, for example, if it's a 3-5, just above the metal foramen, even though you can consider an immediate, I actually don't. I let it heal. And I'll actually wait a bit longer so that I can get a bit more bone fill in that region. So then I don't have to drill as much and I stay away from the metal foramen as much as possible. And of course, everyone knows periodontal conditions, considerations. Yeah. Risk preservation techniques. Okay. Now, it's a general consensus around when I speak to my friends that, oh, let's do the extraction, let's do the grafting, and then we'll call it, they call it socket preservation, which is actually not correct. It's ridge preservation. Right? We want to preserve the ridge, not preserve the socket. Right? If you read this paper, you will see it's generally everything is inconclusive. There's one side of argument which says you need to graft pretty much every socket so you can maintain the volume. The other side says, oh, you let it heal and you can graft at the time of implant placement. So I think each case is different, and I think this is where clinicians with experience have to take a judgment in each case, right? The question of whether you should have primary closure on graft or we should leave it open. These are all things that are there's pros and cons of each procedure. If we let the extraction socket heal with secondary intention, we get slightly better keratinized tissue. So if you were to graft and raise a big flap and close it on top of it, there's a chance that you might one reduce the sulcus depth by pulling over the flap, and of course makes it a lot more traumatic for healing at that stage. And then the soft tissue growth that you get with secondary intention is so much more superior because you get a bit more keratinized tissue. Okay, ideal implant placement. We know all of this. We all do implants, so I think this is a very basic slide for it. We need at least 1.5 millimeters from the adjacent tooth. Between two implants, you want 3 millimeters. You want a prosthetically driven implant planning. You really want you want to go for a screw retained crown as much as possible. And a good prosthetically driven implant planning is crucial for success long term, right? Let's talk about the periodontal consideration when it comes to surgery. Okay, in anteriors, I always like to preserve the papilla if I can, because once you reflect those papillas, there can always be some amount of uh, uh, recession around it, and then it's a bit difficult to come back from such an issue, right? Flap designed to preserve the keratinized tissue, right? I would not go guided. I don't do guided surgery. I don't do punch soft tissue removals, because when you punch a soft tissue, that's the best amount of keratinized tissue you've just taken out and chucked it away. So if you want to do guided, I always tell my friends, if I can, is to use a guide, raise a flap, do your guided surgery if that's what you feel comfortable with, but preserve that keratinized tissue as much as possible, right? Be aware of the anatomy. Periosteal release is important because you want your tensions, you want your surgical site to be closed without tension in the wound, right? Careful handling of the flap. Be careful of the gingival phenotype. Right, let's move on to some more cases. Ash, how am I going with timing?
You're at 7:43, so you've still got about half an hour.
Okay, well,
Yeah.
and should I go a bit faster?
Yeah, otherwise you might have to skip some of your cases. See how you go.
All right, all
Yeah.
right.
Okay.
This is an interesting case. I'll go a bit faster, right? So this is where we compared. This is, I think, one of the first few years of starting to use EthOss for me. So I just wanted to compare how EthOss will work with the xenograft in comparison. So uh, both these teeth were deemed for extraction. So extraction was done. We waited for the soft tissue to heal. 2-1 implant is got EthOss, and 1-1 implant has got Mineros with the membrane that comes with Mineros, right? Azoderm, I think it was what we used. Right? Now we are going in, and this is the healing at stage 2. So good bridge volume, right? But 2-1 has a slightly better soft tissue profile. There was a bit of scarring at the time of surgery. I think I don't know why, but I think I probably wasn't a very skillful surgeon, I suppose, at that time. So the tissues are a bit not as pretty as I'd like them to be. But this is that re-entry. Now we see the 2-1 and the 1-1 implant. So the bone levels are sort of comparable. Bone formation is sort of comparable, right? So and this is the final result. We've got the 2 implants in place, open tray impression, final screw retained pros, and that's the close-up view. So remember now, 2-1 has EthOss and 1-1 has the xenograft. I don't know. I'll let you compare how the sides look. The 1-1 has a bit more soft tissue manipulation, I suppose. When you're trying to tuck a membrane in, put everything in, there is always some amount of tension in the wound, and that probably leads to a little bit of healing with scarring. And this is at a few years after. That's a 5-year follow-up. Yeah, that's a 5-year follow-up of the case. We do see that the 2-1 seems to show superior soft tissue profile even now. Whether it's materially significant, it's a different story. But yeah. from failure to success. This was a very interesting case. This case, when you look at the edentulous span, looks really, really easy. Lots of what it feels like is a lot of bone, but there wasn't inside, but there's good amount of keratinized tissue, good gingival phenotype. So that was all looking really good. So I was feeling very good. We placed 2 implants in, grafted with ethos, same recipe. No change at all. And then I see him for stage 2, and that's what we find. And we were like, oh, so we had to go back to the drawing board, remove both the implants, wait for it to heal again. And I suppose the reason why this incision line opened up is because my incision line was at the wrong spot. That's one thing. And also, he used to wear a denture as a temporary. So I suspect a combination of the incision line not being on really hard bone or stable bone and denture trauma probably opened up the wound, and he was blissfully unaware because he wasn't in pain. Anyway, round 2. We come back, we place 2 implants, we graft. This time we move the incision line slightly more distal so we don't have any risk. And lo and behold, we've got, thankfully, good healing at this stage. So we've got good implants in good position, good keratinized tissue around it. So I think we're happy from here on. And then you've got the implant supported bridge. Okay. Okay. This was a charity case. Now, this guy is a courier delivery guy. And he came in once while he was dropping some couriers. He said, Doc, I'm having some pain in my front tooth. He had it fixed a few years ago. Now, this was a complete charity case. So we said, okay, look, he's a nice guy, so I'll just do it for nothing. Anyway, very interesting case. We've got 2 anteriors which have completely infected. I think there was a fracture in those roots and a massive, massive lesion, which we can see. And this is where the EthOss degranulation burrs come in very, very handy. Right. So extraction's done. The site was curated, and I closed the flap. I let him heal for a while. Called him back in 12 weeks' time. There was no grafting done at that stage. I go back in 12 weeks. There is still some remnants of the lesion still present, right? And that's when I went in and curated that site a second time until I could really, really see good, nice, fresh bone from the osteotomy. 2 implants in place, good insertion torque, buccal defects grafted with EthOss, and primary closure here. Now, this is the X-ray soon at post-op. So you can see you can see the halo around those implants, how deep the EthOss has gone in. This was a wet mix at the top and then dry mix at the bottom. Now, this is when it comes to custom healing abutments. These are implant direct implants, and they come with the fixture mount, which can be used as either a provisional abutment to make a provisional crown, or you can customize it with some flowable composite, polish it, and it really works very well for giving the soft tissue a nice contour. This is at 12 weeks re-entry, and we are now seeing really nice bone development in that region. Right. That's the healing abutments, customized healing abutments, and we are seeing good bone at the at the neckline. So the EthOss that was visible differently on the X-ray now seems to have become homogeneous with the closed bone. And that's just about tension-free closure. We'll move on from there. And that's the setting video. This is, again, I'll just show you. This is how you really want the EthOss to be set when you're just before you close your flap, right? Then open tray impressions, splinter impressions. When we're doing implants next to each other in the anterior zone, creating a papilla in them is the hardest thing. Now, if there are 2 centrals, you at least have the frenum, which you can mask the papilla. With a central and lateral, these are one of the worst cases to do. So in these cases, when I'm doing them, I always tell them that I'll be using pink porcelain before even the extraction. So from get-go that you're not going to be able to create that beautiful papilla in this region. So you have to talk about pink porcelain. Now, this was a complete charity case, so I was going to do the crowns myself. I do some implant crowns on CEREC myself. So we went ahead, took the impressions, I scanned the abutments in, and I then made screw retain. These are screw retain Emax crowns. And Thankfully, his smile line is not very high, so we got away with it. Of course, I asked him to use the fixture in that gap. I said, let's wait, clean it really well. Hopefully, we'll have some amount of papilla fill in. And then a little bit later, I think this was 2 years, and now we are seeing some amount of that papilla coming in. Now, if this was a high aesthetic case, a high demand aesthetic case, I would have probably used a high-end lab for this, and we could have got much nicer prosthetic results. But this is a homemade crown on CEREC, and he's quite happy with it. But what's interesting is the CBCT taken at 2 years. We cannot see the difference between where EthOss was. You remember seeing that halo around the root. EthOss and the host bone is now on a CBCT, completely homogeneous. It's all one. It's all one substance. All right, let's move on. Okay, big defect. History of trauma. Patient was undergoing orthodontics, but you can appreciate how big that defect is. So you know inside there's not going to be much bone before you even started. CBCT done. CBCT was surprisingly actually better because we have a reasonable amount of host bone. But the problem is that bone that is present, it's all too palatal. So you don't want to place an implant in that region, although you have good host bone there, because otherwise you'll have a long, weird looking crown. So anyway, flap raised, and because of the fact that this the tooth was lost to trauma, there was a lot of soft tissue adhesions in that region. So we had to really clean that site very, very well from the soft tissue adhesions. Again, this is the EthOss degranulation burrs. It cleans the bone really, really well. These are diamond coated burrs. You put them on the same handpiece of your implant handpiece, and it just scrubs it really well until you can get to nice, clean host bone. Osteotomy done, we knew that once you position the implant prosthetically where you want it to go, there's not going to be much buccal bone. So the implant is in good bone, still got a good torque on it, good primary stability, and then the buccal was grafted with EthOss. Here I've done EthOss in 2 layers. The first layer, because there was a large defect, so I grafted the first layer, waited for that to set, and then I grafted more on top. And then primary closure, and then we allowed it to heal for 12 weeks. So this is where we started. The first slide is where the implant is with 0 buccal bone, and the last slide is at re-entry. Now, this is interesting that has happened to me, and I've shown this slide to I think, Peter Fairbairn, and he was surprised with that slide as well, because we see there is a bit of granulation tissue there. Now, when I touched that area, there was a little bit of pus, but now I'm expecting once before I go in that the graft is all wasted and it's all gone. But having said that, this is the graft we've got. So we still got about 4 or 5 threads of the implant where the graft is still working, and that possibly some amount of soft tissue trauma, maybe from a chip or a fry that went in and created that little fistula in that region. Anyway, cleaned out the fistula, regrafted a second time, and now we are ready to place the crown. So that's the prosthetic placement of the implant, the screw access coming from the cingulum, and now we can appreciate on the slides on the right how much bone contouring we have achieved with soft tissue as well as hard tissue. Another close-up of the same case. He was almost finishing his ortho, and then we finished up with a screw-retained crown. In this case, I've followed him up for a couple of years, and it's nice and stable. He needs to work on his perio a little bit, but generally, we're quite happy with the result. All right, let's move on. I'll breeze through this case quickly. This is just a posterior case with a failing bridge. She was in a rush to leave the country at that time, so she said, "Can we fix this? Because I have to go." So I had about 6 months to finish this. So we said, "All right, let's do the extraction. Let me degranulate that site. If I can do the implant, I'll do it on the same day. If I can't, then I may not be able to finish your case." But extractions had to be done because she was in pain, and. So we extracted. I could get to clean bone with degranulation. 2 implants in place in immediate extraction sockets. All the buccal area, buccal defects grafted with EthOss. Little bit of sinus lifting. I've done internal osteotomy sinus lift. I don't generally use biomaterial at the tip. I allow for the membrane and the host bone to be there at the tip of the implant in the sinus, and rest is all grafted with EthOss. And then that's at the open tray impression copings. Impression, the bridge is ready, and we extracted the 2.7 because that 2.7 was non-functioning, and I didn't want it to be behind my implant-supported bridge where there was a difficulty in hygiene, right? And that's the final result. So the lower bridge was done, I think, a year before or something, and then we did the upper bridge. Now she's got unilateral implant-supported pros, and if you can see the X-ray up here, you can see that in spite of no bone material, the implant itself holds the sinus lining as a tenting, and we get really good host bone at the tip of the implant just below the sinus. Right, immediate molar, 3/6. I'll run through it quickly. I don't always do immediate molars. These are some cases that I've done, and that's what the ones I'm showing you, but that's not a regular protocol. I got good furcation area for me to anchor my implant, so we went ahead and did the implant. EthOss in the jump space, right? That's at immediate post-op. Soft tissue healing, crown placement. Now on this X-ray, you can see how the EthOss looks on X-rays at 12 weeks. It does not look very nice. And a lot of people get a little anxious. How is that looking? Is that not looking good? Is there resorption there? But at this stage, what the body is trying to do is actually 50% of the EthOss is taken away and new graft is being placed. So if your X-rays look like this at 12 months, 12 weeks of, by the time you're placing the restoration, don't worry. As long as the soft tissue is looking good and clean and the soft tissue cover is good, don't worry about it. This is 3 years, same case. She needed implants in the other side, so we went ahead and did a CBCT, and that's when I could see how the EthOss is now looking. So we've got beautiful bone. That EthOss is converted into host bone. There is what we compared to the X-ray before and now is very different. Anterior case, absolutely no buccal bone, large cystic infection, right? History of trauma, root canal, extraction done. This was a very, very big defect. So flap raised, extraction done. That's how big that defect was. Now, there's a little bit of a debate on whether we should maintain that little bone bridge that you see there. Should we maintain it or should we remove it? Some people are of the opinion that you should remove it. Some people say you should keep it. If it's nice and big and stable, it's probably a good idea to keep it. In this case, I kept it, but it resolved anyways. So implant in the right 3D position. Primary stability was really good because we are engaging the implant in the host bone, right? The rest of it is grafted with EthOss, and we got a primary closure. And then this is healing at 12 weeks before re-entry. Re-entry, flap raised for re-entry, and now we are seeing the plate of bone that we left had resolved because I think it probably lost blood supply. But the good thing about going back in there at a second time of at stage 2 is you can graft again. So peak abutment placed, and we made a provisional crown, a chair side composite provisional crown for this patient after the initial healing. That's the before and that's the after at the time of this X-ray was taken soon at insertion of the crown. So you still see unchanged or unaltered EthOss graft granules, and this is the final, I think, at a year's post-op. I can't be sure, but I think about a year or a year and a half is then when it comes back for review. So a bit of scarring of the soft tissue, but given that this was a very large defect and we had multiple entries into the site, the scarring will only get better as years go by. We can see stable graft on the buccal side. So not a lot of buccal bone, but that's enough. That's enough to maintain the stability of the implant. Right, again, before, after. Let's move on. Yeah. So this was a case. I did a very nice veneer for this patient because he had history of trauma and the tooth had started looking dark. When I first took his X-ray, when he wanted me to do something about the aesthetics of the case, I had a look at the X-ray. I said, "Look, this is replacement resorption. This tooth is not really going to last for too long." But he was going and seeing his in-laws the first time, or something like that. So he said, "Look, doc, I can't go like this." So I took an X-ray. I said, "Hopefully, if you're lucky, this veneer will keep going and the root will stay the way it is, and you at some point will do the implant." As luck would have it, I did the veneer, and then in about 3 months' time, he comes back with pain, saying, "Oh, look at that." So implant it was. Anyway, extraction was done. This patient was again moving to the UK at that stage, and he said, I have only 6 months before I'm leaving, so this had to really go as planned." Extraction done. That site had a lot of granulation, cleaned out, implant in host bone, good primary insertion, buccal area grafted with EthOss, primary closure, and this is how it turns up at stage 2. So again, we are seeing that amount of little bit of granulation tissue, a bit of EthOss particles, sort of graft particles coming out. So when I look at a case like this, I know there is going to be a second round of grafting, probably some amount of pressure in the incision, which might have opened up, some amount of soft tissue trauma from the denture. Anyway, so we went in and we can see that there is a little bit of graft failure. Not all the way, but there is some graft failure in that region. So thankfully, the implant is well integrated because the implant is not deriving support from the graft. It's all in the host bone. Buccal defect was grafted with EthOss, healing abutment, customized healing abutment, sutured up, right? And then hope for the best that he heals well. He healed all right, just in time for making an impression. And we placed a crown. Sorry, this is a post-op, but we placed a crown just before he was leaving for the UK. And then he comes back after a couple of years. He was in the UK for a year, I think, and then he came back 6 months after he came back. So this is about a 2-year follow-up, and that's the one crown. I think it's nice and stable. And we can also see that there is good amount of bone stability on the buccal where we had lost all that bone and where there was so much infection. Now it's nice and stable because the soft tissue cover on it is nice and stable as well. Right, that's just the same case in the full perspective where you have the before with external resorption, replacement resorption, and then the final result. Okay. This was a perio grafting case. I saw this patient after the extractions were already done. Anyway, I've taken this video to show for people who don't do flap surgeries, just to show how we raise a flap and make sure that you treat the flap really, really well, really carefully. Be nice to it, be gentle, take your time when you're raising a flap. There is no rush, right? We know that we are going to graft in this case. There's no point in going guided, right? Or fully guided. You can make a guide for your prosthetic bit, but if you went punch and went guide, there is no way you can do this case. Okay, I'll move on. That's the video of the osteotomy. And then we've got the implant going in as well. So the reason why I took this video and I'm placed it over here is for people who are sort of new at placing implants. When you're doing osteotomy in a parallel situation, when I'm doing the 2-1 osteotomy for that matter, I'm trying to change the angle of my handpiece because your general arc of your handpiece is like this. So you will end up with a wrong angulation. So when you go up in that region, you have to compensate for that arc of your movement. Sorry, this is not EthOss, it's just general stuff. But again, we got good primary stability in both these areas. I know we have almost no buccal bone there, but we're going to graft this site after. Right? So implants are at the right depth, right prosthetic angle. So you want the we're getting ready for a screw retained prosthesis on this, and that's where you want the implants to be placed. And then this is a whole video of grafting with EthOss. So I've already prepared the site in this region. Muted. And then I'm preparing the graft, mixing it with saline. Now, there are times when I end up, as much as I would not like to, I end up placing a little bit more saline in it accidentally, really. But with EthOss, it's 1:1 saline, and it's almost better if you place a little less saline. So if it's a little bit dryish on the dryish side, it's actually better manipulation. Because if you place too much saline in it and you just dab it, I mean, here I didn't dab too much, but if you dab away everything, then you will lose all the calcium sulfate from mixing it with saline. Now the site is ready for us to go and place the EthOss. So we're just placing the graft there. I'll go a little bit faster on this video. We've placed the graft. Then we've got manipulating that area, packing it really well, as if you're doing some stone sculpting. Let's move forward. Yeah. And then this is how you really want the surgical site to be nice and dry, clean, free from infection.
You got about 5 to 10 minutes, Nick.
Okay, well, I think we're coming to the end of it.
Wonderful.
Okay. Is everyone asleep?
No, definitely not. But I don't want to run out of time.
All right. All right, let's move on. And then on the slide next door, we've got the primary closure. It's moving on. This is at re-entry. So we did that big graft in that region. And in such cases, I know I'm going to lose some amount of graft. So I really don't want to place healing abutments on the day one and then have no entry again. So we are looking at a 2-stage grafting procedure in this patient. At re-entry, we are seeing good amount of bone on the 2-1 implant. 1-1, we still have a good amount of bone, but seem to have lost a little bit of graft over there. So then we go back in and then we regraft. Same recipe, same principles are followed. We regraft the whole site again. We place, we make sure it's nicely set. That's the setting video. Right, you want your elevator to the back of the elevator to tap off on it, right? Let's move on. And then suturing. Suturing has to be critically, well, suturing is a critical part of everything. You need to really make sure you've got nice tension-free closure. The knots are away from the incision line so that you don't get too much plaque buildup. Same basic principles of surgery. And this is where we see good healing. Now, we've got good, in this angle in the bird's eye view, we can see there's good amount of buccal volume, good keratinized tissue. So generally, we are quite happy with that. But in this case, even before I started this case, again, I told her we are going to use some amount of pink porcelain because we've lost vertical. We cannot really gain vertical that predictably. And this is the result in the end. So screw retained pros. The lab did a beautiful job of making really nice crowns. And that pink porcelain is added, which looks quite nice in the smile line. So this photo is taken at insertion. So there's a bit of blanching of the tissue. And that's the final X-rays and final post-op in the smile. Now, with the smile line like that, if we had not placed any pink porcelain, that would have looked very, very unsightly. So these are some of the things that you need to discuss before you start the cases. Simple case, it's a repetition of the case, so I'm going to move this case faster. The only difference in this case was we had a large lesion, but the buccal bone was intact, and this is all EthOss. Ash, can you see my cursor?
Yes.
Yeah. So all of this is actually EthOss. So this implant is almost floating in grafting. Now, we left it to heal for 12 to 14 weeks, a little bit longer in this case, and then I've placed a provisional crown. So this is the provisional crown, but we're already seeing bone turnover. We're already seeing on the X-ray that the white opaque granular graft is now becoming homogeneous with the bone. And then I did some progressive loading in this, in the sense that you place the temporary crown on it and leave it a bit longer before you go for final pros, because a little bit of stimulation of the bone will make the bone more remineralized when you're ready, before you place the final crown. And that's the final result at 2 years. So we're getting the graft and the host bone is now indifferentiable, good soft tissue cover, and that's the final crown. Okay, similar case to what we did before. Very similar. You can see a pattern now. It's all pretty much similar. And that's the CBCT after loading. This is my provisional crown on the 1-1. This was just a chairside composite crown before I take the impression. And the final photo on the top here is actually the final zirconia crown. And funny enough, I kind of prefer the aesthetics and the value of the composite crown over the ceramic crown, because the ceramic crown looks a little bit gray. Patient's not complaining much, so I've not really replaced it. But yeah, I can spot the difference. Ash told me to put in a bit of molar stuff, because everyone's going to be interested in grafting, or sinus grafting, really. So this is a case that we see very commonly. Upper molar infected root canal needs to go, and then once we extract it, we are not going to have enough bone below the sinus to do anything predictable, right? So this is a 1/6. That X-ray has been inverted. Actually, it's actually a 1/6 implant. And large defect extraction was done. Complete curettage of the site was done. We allowed it to heal with just primary, not primary closure, but primary healing, with just a blood clot, actually, and sutures taken crisscross, just to make sure that the wounds are staying, basically sutures for hemostasis, not for anything else. And then before the implant placement, you've got this nice. So when you allow, I was talking about it before, when you allow with the tissues to heal with secondary intention, you get a lot more beautiful keratinized tissue. This is gold. This is good real estate around the implant. Implant in position. I done a bit of osteotomy. I've used a shorter implant in this region. And then the buccal defect was grafted with EthOss. Primary closure again, because we know that we might have to graft a second time. So primary closure taken. That's at the time of placement. That's at the time of the crown insertion, right? So now most people will think, and I thought the same way as well. How is this going to look? The graft seems to have been completely washed off, and there's a lot of radiolucency around the neck of my implant. Am I losing bone on that implant? But I know for a fact that it's not. It's just there's a resorptive process before an additive process. So this is exactly at 3 months since the time the implant was done. So we know on a cellular level or a biological level, that's what's happening inside. So I wasn't too worried about it. And then that's the 2 years follow-up. So under loading, now we are seeing good amount of bone return at that area. And this is the 5-year post-op, and he's a regular patient of my practice. He's a bruxa. He's a horrible bruxa. I made him a splint, but 5 years, and it's been stable. We've not really had any problems with this case, not even screw loosening. So I'm thinking this is working out really well. We are seeing good cortical bone deposition at the tip of the implant, and even at the neck of the implant, we are seeing there is good amount of bone there. So nice and stable result using biology in our favor. This is just a repetition of what I was saying, right? So prosthetically driven implant planning, soft tissue and hard tissue management. There are no magic materials. All materials will work. It's about the convenience, ease of use, support, and what works best in your hand. Respect biology. We cannot really replicate humans as such in our grafting sites. So We have to work with what we've got, and we cannot really overstep our line when it comes to biology. Okay, discuss failures openly with patients. In the beginning, when I started off, I used to be a bit ashamed of discussing failures, but now I'm talking more failures than successes in my informed consents. And thank you very much for staying awake. And I'm so sorry today for a bit of the audio issue, but I think we made it in the end, and I hope we got it on time. Ash, are we on time, Ash?
You're bang on time, possibly 30
Beautiful.
seconds over. So thank you so much.
You want me to
Uh,
keep talking for 30 seconds?
no, I don't want you to keep
No,
talking
I'll
for
shut up.
30
Okay.
seconds. We're going to hand over to Dr. Minu Vellani, who
Should I
will
stop
now
share?
yes, please, who will now take us through a small presentation that he has put together for you on dental sedation. So, Manu, I'll leave it over to you. You can share your screen.
I think Nick has to stop sharing.
I did.
He did. So now you can share yours
Hmm.
on your original screen.
Yeah.
We can hear you, Minu. We can speak to
Okay.
you.
Here we go, guys. Okay, can you see my screen?
Not yet.
No.
There we go. How's that?
Yes, I can see that now. Thank you so much.
Beautiful.
Okay, Nick, just
Okay.
mute your thing so it doesn't go over to your camera. Okay, thank you.
All right. Good evening, everyone. Look, thanks for sticking around. Again, I want to apologize for the late start as well. And I'm very conscious of the time now, so I am going to make this fairly snappy, but I want to try and give you as much value as I can. There's two separate presentations I'm going to deliver. The first is what I bring to the table, and if you are doing anything with implants and/or grafting, sooner or later you're going to need this sort of a service, I would suggest. And the second is a very unique offering that Nick and I have for the dental community, which I'd like to share with you. Okay, so how to attract the 49% of patients who fear coming to the to your practice. And I'll come to how I've got that figure of 49% in a minute. Now, if you don't like that title, well, how about this? How can you offer more services, increase your production, and differentiate your practice all at the same time? Okay, so I'd like you to imagine just for a minute, please. Okay, this is going to be very hard to believe, but you just need to just go with me here. Just imagine if you could assure every single patient of yours that they're going to have a very safe, comfortable, relaxing experience. They're not going to remember anything. They're going to feel like no time has passed at all. And they're basically just going to have a very deep, satisfying sleep. And all of this while you are going to be super efficient and super productive. I mean, this is dental nirvana, really. Okay. And so what I'm talking about is intravenous sedation. It goes along many names. It used to be called conscious sedation, but now the proper term is moderate procedural sedation. Okay. So just a little bit about me first. For those who don't know me, my name's Minu Vellani. I head Bespoke Dental Sedation. I'm a dentist with 30 years experience. I did my grad dip back in 2006, and which makes me a dental board approved sedationist. But, you know, why me? Why should you be listening to me about this? Well, first and foremost, I'm a dentist. And this is so important. I genuinely believe this, that there is no better model than a dentist providing sedation to another dentist. Sedation dentistry is very subtle. It's not like general anesthesia. And unfortunately, I don't have time to go into that debate right now, but I'm happy to take questions at the end. Also, my experience. This is 20 years for me now, and I've done well over 5,000 cases. So You know, I'm one of the more senior sedationists in Australia now. I'm very mobile, very happy to travel. My practice now extends through to 4 states in Australia. I'm constantly on an aircraft somewhere. I basically said that, you know, I just want to work with the very best dentists wherever they are. And the last thing is I've got a lot of testimonials, both from dentists and patients. I've got over 550 5-star Google reviews. And the only reason I'm saying that, guys, is because they might be my reviews, but they are your goodwill. I'm going to repeat that. They might be my reviews, but they are your goodwill. It is your patient at the end of the day. So think about that. Okay. Now, and again, I apologize for the speed of this presentation, but I don't want to keep you as any longer than I have to. So I'm going to discuss things from the patient experience now. And SBS has this current affairs program called Insight, which you may know of. And a few years ago, they had a whole thing on the dental profession, and it was a real big reality check. Okay, there were stories of patients with severe phobias. Almost everyone mentioned how scared they were, and the big takeaway was this: there are just not enough dentists catering for people with fear and anxiety. Okay. This is where I got that figure of 49% from. It was in the Australian Dental Journal, so you can look it up. I have seen research papers with figures that vary anywhere between 25% and 60%. So even if in your mind you think of the figure of 25%, that's 1 in 4 of your patients that are desperately seeking pain-free, fear-free dentistry. Okay. So why is IV sedation so popular? Okay. Well, these are the obvious reasons. It's very safe, very comfortable. The recovery is usually very smooth and rapid, and it's very convenient for both the practitioner and the patient. But the 3 big reasons, in my opinion, are it is customizable. So it's absolutely, it can be tailored to both the patient and the dentist. It provides absolute pain-free, worry-free, fear-free dentistry, totally absolute. And the best one of all, it is amnesic. So the patients have very little, if any, recollection of the entire experience. Okay. Some of the feedback that I've received from patients, and trust me, I have not cherry-picked any of these. I've got way better reviews than this, but it just generally, summarizes what patients think of all of this. I definitely recommend this service to anyone who has dental anxiety. I was unable to feel anything at all. I could not have asked for a better process to happen. Remember, this is all your goodwill. It's not my goodwill. Okay, and I just want to make a very deliberate statement there that, with my 20 years of experience, I can categorically say, and I hand on my heart, that I believe conscious sedation is simply the most comfortable way of having your dentistry done, bar none, when you take all the factors into account. Okay, now I want to talk, so that's from the patient's point of view. I want to talk about it from your point of view, and just a quick snapshot of production. Now, in my more detailed presentation, I go through a whole exercise with my audience, and it just blows their mind. But if I can graphically illustrate, for example, if your typical day of dentistry in terms of production is like that, well then a typical morning of sedation dentistry should at least equal your typical day's production, if not increase it slightly. An average day of sedation dentistry will at least double, if not triple, your normal day. And an outstanding day of sedation dentistry will just blow your mind. I have a few practices that do these amazing days weekly. And they frankly, they could not do it without sedation. Okay. So Some of the feedback that I've got from my dentist, again, I've got many. These are just three. Nothing has had a greater impact on my practice. All these three practitioners are very senior practitioners, so they're very experienced. You know, I would highly recommend the use of IV sedation, and sedation has categorically changed my approach to complex dental treatment. Okay, now you need to do a couple of things. It's really simple, guys. You don't have to overcomplicate this. For people who have never, ever introduced sedation into their practices, there's two main things: oxygen and scheduling. Okay, so I'll briefly touch on both those. Oxygen is mandatory. You're going to have it. All right. And the good thing is, if you're providing nitrous oxide sedation, well, guess what? You've already got oxygen on the premises. So it becomes now a zero cost exercise for you to introduce IV sedation. Okay. In terms of scheduling, you have to realize you need more time with anesthesia. There is an induction time, which is generally about 15 to 20 minutes, and there's a recovery time. So generally, you're going to need 1 more hour for your for your time than the dental procedure. So if, for example, your procedure goes for, let's say, an hour and a half, you're going to need to block out 2.5 hours for this patient. And if you do that, you're basically going to run on time all day long. So oxygen and scheduling, they're the two main criteria. Now, what sort of patients should you even be looking at for this sort of stuff? Well, obviously the anxious and phobic patients, that's a no-brainer, all right? But patients who are neither anxious nor phobic but are having long, unpleasant procedures and want it done without any distress. Treatment that can take multiple visits can now be compressed. More and more of us are time poor, so this is a huge market that I'm finding, okay? It has nothing to do with anxiety or phobia. The inconvenience of general anesthesia, and getting access to general anesthesia now for dentists and even dental specialists is getting harder and harder and harder, if not impossible. And then finally, in terms of teaching and learning, teaching for the mentors, learning for the students, it's a fantastic, it's actually the most ideal environment, because you can have a freedom of communication back and forth between teacher and student without the patient being aware of what's happening. But other indications, excellent to control gagging. It's, you know, those patients that are exquisitely sensitive. It's really good for those. Patients with hypertension or some mild cardiovascular disease, fantastic for those, because it lowers and slows everything down. And of course, special needs patients. Now, I've treated patients in all those categories. In fact, I did a severe autistic patient today. So they are very amenable to IV sedation, and I can assure you their parents and carers are very, very grateful. Now, some of the things I hear from practices, okay? It's great for patients because they don't remember a thing. This is typically what a dental assistant says to me. The team really like sedation days and find them more relaxing because the patient is asleep. That is typically a practice manager or a front desk person that tells me that. I can't believe how easy it was. That is the classic statement I hear from a newbie dentist who's doing sedation for the very first time. Okay. And then the one comment I get from the very experienced practitioners is that, you know, if I could, I'd do all my work under IV. And the reason for that, ladies and gentlemen, is they are super productive. There's no chit chat. They're in, they do their work, and they're out. Okay, now I want to dispel some fallacies. I've got many, but I'm just going to focus on the 3 most common ones. First fallacy I hear, you need a special, you know, I'd love to do this, but I don't have a special recovery room. Well, you know what? You don't need one. There is no need for it. In fact, I personally prefer the patients left in the treatment room or the procedure room rather than it being moved prematurely to a recovery room. Okay, that's fallacy number one. Fallacy number two, oh my God, I'm going to need extra staff for this. No, you're not. You do your dentistry normally. Everything is normal, including LA, everything. If you work with one staff member, you work with one. If you work with three, you work with three. Okay? And remember, you have a sedationist in the room. So you have another person, another pair of hands that you can utilize. Okay, and fallacy number three, this is the biggest one of the lot. And I really, if there's one thing I want you to take away from this presentation today, it's this, that sedation is prone to emergencies. It's absolute garbage. I've been doing it for 20 years, and touch wood, I have never, ever experienced one. In fact, sedation lowers the incidence of medical emergencies, and there is a reason for that. Most medical emergencies, especially in a dental practice, stem from stress and anxiety. So if you can relieve that right from the start, you have eliminated that cascade of events. The other way I want you to look at this is flip it around. Let's imagine we do have a medical emergency. Well, guess what? The management of that emergency now becomes a lot easier because we've already got intravenous access. That's the first thing that an ambulance person will be doing anyway. Okay? So just food for thought. All right. So key takeaways now. Controlling pain and anxiety is a fundamental expectation of patients now. It's not like when it was 30, 35 years ago when I graduated, okay? Just can't get away with that sort of nonsense. Second point, IV sedation is, it will give you the biggest bang for your buck in dentistry, in my opinion. Nothing will come even close to it. And thirdly, it is a win-win-win environment. I'll come to that in a minute. Don't kid yourself. This is what at least 25% of your patients are feeling, whether they tell you or not. Okay? And this is the end result. This is what we're aiming to do. Okay, now I want to show you a video. It's only short, and it's of Nick and I in an IV sedation procedure. That's my setup. As you can see, the footprint is not large. And you'll see here the patient has a blanket because patients often get cold under sedation. Now you'll hear Nick and the assistant talk to the patient. Okay, and which means the patient is hearing things. The patient is responsive, even though their eyes are closed and they're still. However, they won't remember any of it. Okay. So if Nick wants them to open wider, he'll just tell them to, and they will. They'll respond. So that's the perfect level of conscious sedation. Everything else is normal,
Sorry, Minu. Just quickly, how much longer do you think you've got? Because I want to get to the Q&As before
Okay, I've
people
probably
start.
got about another 5 to 10 minutes max.
Okay, I just want to get to the Q&A before people start to jump off.
Okay, okay. So I'll stop that and move on if I could. All right, so it's a win-win-win environment, a win for your patients, win for your staff and for you, and it's a win for your practice. Now, this is the real takeaway. It's a huge competitive advantage. I've seen it in practices in 4 states in Australia, and the question I have for you is, what would delivering dentistry like this have or mean for your practice? All right. Thank you very much. They're my details. If you want to take a photo of that or a screenshot, whatever. If you'd like to talk to me about sedation, always welcome to have a chat. Okay. So I'll leave that on for a sec more, and then I'll move on very quickly to my next presentation, which is combining IV sedation and implants. So Nick and I have a very unique offering in the dental profession. We have a course that we entitled Place Your First Implant and differentiate yourself with IV sedation. Okay, so that's enough about the two of us. You know about the two of us. Okay, it's a 2-day intensive course. There's 14 hours of CPD. It's being done in a Sydney location, and I'll go through what's involved. So we do a talk. We start off with a talk on the medical considerations in the implant patient. We then talk about implant biomechanics, implant surfaces, occlusion, flap design, impression techniques, grafting materials and grafting techniques. I give a very detailed talk on absolute pain-free, worry-free, fear-free dentistry. How do we do it? The pros and cons, everything in detail. That's basically all day one. We also include on day one practical hands-on component on models, so you can really have a good play around. On day two, it's really special because we have a live patient where Nick does a surgical procedure or a grafting procedure and under sedation. So every attendee actually sees us live working in a real environment. And, it's fully taped and then, question and answers afterwards. But the real big bonus in this is the mentorship that's attached with all of this, okay? So attendees can come and get mentored at Nick's practice in Leichhardt. They will basically be an associate in that practice, so they will get a commission, and which means basically that you can virtually pay for the whole course with your first case alone. So it's again very risk-free, great way of mentoring, and you have access to Nick and I as you require. So that's just a bonus. Now, this is our first group that we had. The lady sitting in the chair is the patient we actually sedated for an implant, and I'll skip this, I think. And I'll just move on to the last slide. This is the last slide, actually. Just some details about our next course, okay? It's going to be held on Saturday, July 11 and Sunday, July 12. We always do it. We tend to always do it on a weekend, so it doesn't interfere with your Monday to Friday schedules, okay? It's going to be in Sydney, in Alexandria, at the Dental Education Centre, and the cost is $1,495, and that is not a typo. That's what it is. Remember, it's for 2 days. Lunch is catered on both days, a live patient, and mentoring. I just want to say that is only for a strictly limited time. We are probably never going to repeat it at this price ever again. And that's it. That's it for me. Thank you, Ashley.
Thank you so much. And I'll put my little 2 cents in with that. I was a part of Nick and Minu's last course that they ran, and it is very professional and very educational heavy. So I think anybody that is interested, please take up the offer because it is a wonderful opportunity. So we'll move on to some questions. Nick, I know you have answered a couple for some that had to leave, but we'll go over a few of them so people can hear them. So the first one is, how long after the socket graft can the implant be placed?
12 weeks, I would say.
12 weeks. Excellent. Can EthOss be used for grafting for a bony pocket?
Basically for perio, and I've actually had very good results with perio grafting. The great part about EthOss and the whole reason why we get perio disease in an open flap procedure, you're essentially trying to eliminate the pocket, right? So imagine you've got a deep pocket, you've raised a flap, you've curated everything, you've root planed it, the bone is nice and clean now. But if you just close it back on, the soft tissue is still going to fall in that region. So when you pack EthOss like a dental plaster around that root in the infrabony defect, and then you place your flap back onto that area, it actually provides a beautiful bed for the soft tissue to be supported. And so you can eliminate periodontal defects and pockets really, really well and really predictably. Now, I'm not entirely sure whether Ethos, when it came as a product, I don't think they're marketing it as a perio product, is it, Ash?
They don't have a lot
It's
of studies with perio because you
correct.
don't necessarily
Correct.
go in and remove a healthy perio graft once you've done it. So it's not like doing a socket where you can get a
Yeah,
core
yeah,
sample from it to get a histology screening. So
yeah,
they are slowly gathering perio data, but it
yeah.
is not perio data heavy.
And the Ethos UK actually asked me for photos, but the thing is, I never bothered taking any photos because at that time I was just using it for perio. But now actually they're asking me to document and record those cases more. They say we don't care about the implant grafting. Now we know that works. Can you get us some perio one? And so yeah, and so I think I'm looking at in the next webinar, hopefully I'll have some more perio. But again,
Fantastic.
documenting perio and proving perio grafting over time is a bit difficult, even on X-rays, even on everything. Like, essentially you're checking for bleeding on probing and all of those things, it makes very hard slides and they're not very catchy. So it's difficult to show. But yes, perio, yes, absolutely. By the way,
Excellent.
guys, wherever you use bone grafting, you have to make sure everything will work well. You have to make sure that it's completely disease free. So when you talk about socket grafting, it's not about taking the tooth out and popping the graft in. It's about actually degranulating that site really, really well. And sometimes you've got to be careful in cases where you've got, let's say, a 4-6, and you got the nerve just below it, and sometimes the nerve has no cortical plate on top of it, so you've got to be careful when you degranulate it. So I wouldn't stick a graft in that socket if I'm not sure if I've degranulated really well. In that case, I'm better off degranulating as much as I can, letting it heal, and then doing a CBCT at 8 weeks or so. So I know socket everyone likes socket grafting, but I would say use it sparingly, use it carefully.
Okay. The next one is why does the soft tissue not infiltrate the graft
Yeah.
compared to other grafts when you're not using a separate membrane?
Because ethos, the calcium sulfate in the ethos, and this is why the manipulation of ethos is critical. If you make a spongy mix and you stick it over there and it's all over the shop, it's not going to work. It's all going to get washed off. So you need to really learn how to mix it. Essentially, I always tell people, essentially mix it like dental plaster. And before you close your flap, make sure it looks like your model. It's simple. So you have to think over there in surgery, you have to not think as a surgeon, but you have to think as a prosthetist, actually, when you're pouring stone casts.
Okay.
Um,
That will
what do you
come
think?
into the next question. I think it'll flow into, do you
Yeah.
measure the saline wet or dry mixes and
Mhm.
any other guidelines for saline quantity when mixing?
So usually 1:1, but less is more.
Yeah, so you've put on, I'll pipe in on this one. You've put 1 to 1. Um, Ethos is designed to be mixed at a 1 to 1 ratio at its very, very maximum. Ideally, you would like to have it a little bit less than a 1 to 1 ratio. This allows you to minimize the calcium sulfate that you flush out. So the more calcium sulfate rich we can keep Ethos, the harder and more predictable end result we get in handling. So Ethos can be very predictable in its handling and setting as long as we're not flushing out too much calcium sulfate. Now, the science for the calcium sulfate at a 1 to 1 ratio is what the science and the histology screening measure with the 50% host bone at 12 weeks because it doesn't allow the soft tissue to ingress. So allowing you to maintain a little bit more calcium sulfate at the beginning when it's handling just makes your life a little bit easier. So never go above a 1 to 1 ratio. If you can, go just under that. Keep in mind the thicker the mix, the less handling time you have. Like Nick said, think of it as mixing plaster. The thicker you have your plaster, the less water you add, the quicker the plaster is going to set. So just keep in mind your setting time when you are mixing. and where you're actually going to place your EthOss. Just have that thought process before you do mix. Anything to add to that, Nick?
No, no.
Okay. In your hands, is EthOss rock hard, or does it still have a little bit of sponginess?
No, I wait for it to be rock hard. And that means one of two things. You probably put too much water. But once it's all dried up, it has to, the elevator has to bounce off it, like I've shown in some of the videos.
Yeah. Okay. I'm going to give this one to you. You've said you haven't really done it, but I'll finish off with this question. Using EthOss outside the bony envelope almost always requires a tie mesh or a PDS-20 suture. Or can we still get decent bone regeneration without providing the implants are placed as well?
I sort of answered that question. I didn't quite get it. I mean, the implants are at the correct prosthetic position, and then we're trying to develop bone. Is that the question? I sort of lost it. But look, I don't use, none of my cases I've shown you, I've shown the two PDS, but I buy the argument behind it. It adds as another tenting area or a matrix for the graft to set. And I suppose it's valid to use it. But we all know from biology that if you're trying to grow bone out of the bony envelope, it's not really predictable. Like uh, I don't know. What do you think?
Yeah, no, I agree.
Hard to grow it outside the. I mean, I don't think there are any papers which vouch saying, "Oh, this is how you grow bone outside the bony envelope." I don't think it's really done
No,
measurably or predictably, for that matter.
I don't think so.
No.
Okay, once again, I'd want to say a huge thank you to Nick and to Dr. Manu. And thank you for all of your time this evening. I will once again pop this amazing offer on the screen that is available to our webinar attendees this evening. Like I said, you can contact ARC Health, or there is my number. You can take a screenshot of that. And yeah, thank you to everybody that attended. Sorry that we did go over time with a little bit of technical issues, but I think you all got a lot out of that, and the cases were phenomenal. So thank you very much, everybody.
Thank you.
Pleasure.
Thanks a lot.
Ash, I just wanted to say one thing about the course that Minu described.
Yes.
Look, I know most people who are attending this are doing implants, but spread the word to your associates. And if you have an associate who you want to get trained for implants, that they can help you in your practice, right? If they're very rough and new, you send them to the course. It's not a big cost outlay. And then they are ready to help you, at least with the implant prosthetics, or increase your billing that way. So thank you for having a listen.
Yeah.
No worries. Thank you so much, Nick. Thank you, Manu, and I look forward to seeing you in the practice soon.
Yeah, sure. Absolutely.
Take care.
Thanks. Bye, guys.
Bye.